I want to welcome to the stage our next panel, and we will be getting some additional chairs for this next panel. Oh, chair people, here they come. This next panel is an exciting one that we decided to put together in response largely to the Dobbs decision. I also want to say for people who are standing, I'm glad to see people coming down. There's room in the front 2 rows and more. Sorry for those poor counting skills. Thank you for the additional chairs. And as the panel comes out, I'm going to move to my official spot. Hello, everyone.
Hello.
As fearless moderator. As I was saying, the foundation thinks about healthcare broadly. We like to say things that we mean, like mental health is health. Mm-hmm. But after the Dobbs decision, we started to have some conversations about the criminalization of healthcare. And I started to think about the criminalization of healthcare anywhere is the criminalization of healthcare everywhere. And when I start to take on new questions, or I'm trying personally to respond to change in the world, I always turn first to history. And so I started to think about over time, what forms of healthcare have been criminalized? What has the impact been? Have certain types of healthcare always been criminalized? And what is the impact of the criminalization of healthcare when it comes to losing one's bodily autonomy, privacy rights, or perhaps being subject to less than quality care, or receiving quality care in less than quality environments? And so I turned to colleagues and friends and assembled this panel of crackerjack experts. Starting from my left is Kassandra Frederique, who is the leader of the Drug Policy Alliance. To Kassandra's left is Lourdes Rivera, who leads Pregnancy Justice. And to Lourdes' left is Nathan Cisneros, who runs the HIV Criminalization Project at the Williams Center at UCLA. All of their biographical statements are in their programs. And so I want to get right to our conversation. And I think the best way to get right to this conversation is to level set with data, because data tells a story in black and white about what is happening with the criminalization of 3 types of healthcare issues or matters that are before us. And Kassandra, I believe you are going first.
That is definitely.
Does that sound right to you?
Yeah.
Although I have failed in my moderator duties by not giving you what I call the clicker.
Yes. I was worried.
I know, you're like, where's my clicker?
I was like, my telepathy is not that strong.
I know, I lost a point. I lost a point with the clicker.
Awesome. So I'm going to go fast because being first means I keep the pace for everyone else.
That's why you're going first.
All right, let's do it. All right, so again, as Melissa said, I'm the executive director at Drug Policy Alliance, national organization working to end the criminalization of drugs, repair the harms, and also create alternative structures on how we deal with drugs in society. So I've been asked to talk about drug criminalization. Every 31 seconds, someone is arrested for drugs. There have been over 1 million arrests in the last year. Overwhelmingly, most of them are for drug possession. So 85% of the arrests that people are having is because they possess drugs. And the racial disparities are what you think. Despite there being 13% of the population, Black Americans are 24% of the arrests that are happening. And that's not just because Black people have drugs, that's because of the targeted enforcement and surveillance and punishment that happens. People often talk about the role of criminalization of drugs and mass incarceration. It's not mass incarceration. Mass incarceration is not driven by drug criminalization. Only 1 in 5 people that are currently incarcerated are incarcerated because of drugs. And the people that are incarcerated for drugs are most likely to be incarcerated in prison because of sales and manufacturing. And so if we're gonna actually have a conversation about ending the war on drugs, we do need to have a conversation about dealing with the sale and trade of drugs, but that's at a DPA conference and not here. I will say, though, that in the conversation of drug criminalization, jails is really where we need to focus. Jails are a critical area of focus that is often overlooked. According to the Prison Policy Initiative, in 2022, about 469,000 people enter prison gates. But people went to jail 7 million times more. So jails is where we see most drug arrests. People are going in and out, in and out. At least 1 in 4 people who go to jail will be arrested again within the same year. Often those are dealing with poverty, mental illness, substance use disorders, and whose problems only worsen with incarceration. Not only is incarceration a problem, 20% of the people that are incarcerated on these drugs charges, that's what I said, 1 in 5, but nearly half of the people that are incarcerated in jails are diagnosable with substance use disorder or mental health. So even if they're not there for drugs or mental health, they're there. One of the exacerbating factors of them being predisposed to incarceration and criminalization and stigmatization is that. And it is actually killing people being engaged in the criminal legal system. Anyone within the first 2 weeks of people leaving are 27 times more likely to die in the first 2 weeks. Also, this stat right here is really important to see that fatal overdose deaths have gone up 600% inside of prisons, 400% inside of jails. Arrest doesn't always mean that someone is incarcerated. It also means that we see that criminalization often is used as a way to bar people from getting access to supports like housing, supports for family supports, immigration deportation, housing, all things that keep someone healthy. So really, when we ask the question, does anyone really deserve access to healthcare, we realize that if we criminalize them, we make that impossible. And not only does the criminalization of drugs make it impossible for people to access healthcare or make them more likely to die, it's the fact that our strategy around drugs has made it actually impossible for us to actually help them. So our carceral way of moving in dealing with drugs has actually made it more difficult for us to actually get people the medications that are necessary for people to deal with addiction. So methadone, buprenorphine are all shaped by our strategy of criminalization. Not only that, it makes it impossible for us to give people access to syringes or safer smoking kits. And in the moment that we're in right now, where we have so many people on the street that are using drugs publicly, we are unable to put things together like overdose prevention centers because our laws make it impossible to do so. So criminalization of the healthcare of people that use drugs make it impossible for us to get them the medications, but also to put the interventions that are necessary in place because of how we deal with it. And then we make the help that people do get more difficult, because when we force people into treatment because of criminalization, they are 3.5 times more likely to overdose compared to people that have never been involuntarily committed. What is this versus what is this? What is this versus what is this? One of this is a jail and one of this is a prison. One of this is a, now I've lost my clicker, Lord. One of this is jail and one of this is treatment, but they look the same. Mm-hmm. And the cost of this is overdose. Look at that line. Has gone up even higher. Over 108,000 people died in 2022.
Well, thank you for that presentation, Kassandra. Lourdes.
Great, thank you. So I'm Lourdes Rivera. I'm president of Pregnancy Justice. And we advocate and defend people who are pregnant and are criminalized and treated punitively because of their pregnancy status. And one of the things that we've done is track cases of pregnancy criminalization. But I first want to start with what is the definition of pregnancy criminalization? This is an Amnesty International definition, and it is the penalizing and punishing of individuals for actions that otherwise would not be criminal, but for the pregnancy status. And we also see the punishing and criminalizing of pregnancy outcomes of miscarriages and stillbirths, which happens naturally. But in this environment that we're in, miscarriages and stillbirths, particularly for certain groups of people, it becomes a suspect event. So in our research, so we've done 2 research projects. Our first project, we found, I don't know what happened to those numbers. They kind of disappeared. In that first period between 1973 and 2005, we found 413 reported cases of pregnancy criminalization. In the research that we published in September, this past September, covering 2005 to June 2022, when the Dobbs decision was decided, we found almost 1,400 cases. So that was basically triple the number of cases in half the time. So this has been an accelerating trend of criminalizing pregnant people. So what's been happening during that time? So one is the expansion of granting fetuses, fertilized eggs, and embryos separate legal status in state law. So that's been expanding. Increasing of abortion restrictions and now bans, which the granting of fetal personhood has contributed to. Increased maternal mortality and morbidity rates, and overdose deaths and suicide among pregnant and postpartum people has been escalating and contributing to that escalating maternal mortality rate. And what has remained consistent is the paltry substance use disorder treatment for pregnant and parenting people. This is in our research. I mean, we have found at least 1 case in 46 states and U.S. territories, but this is really a Southern story. The 4 out of 5 of the cases of those almost 1,400 cases come from these 5 states, with Alabama leading the way with almost 650 cases of criminalization. And the grounds for arrests show that this is primarily brought in the context of substance use during pregnancy. So this represents the merging of fetal personhood with the war on drugs that Kassandra talked about. So 9 out of 10 of these cases, that really long bar, cases involve allegations of substance use, not possession, which is what is the illegal act, substance use, which in most states in the country is not an illegal act. 1/4 of these cases involve alleged use of legal substances, including prescribed medication under the care of a doctor, including prescribed medication to help manage opioid use disorder. And of course, as Kassandra indicated, this is drug testing. Who is targeted? It's a very racialized surveillance system. Black women in particular are targeted, and they are overrepresented in the data. But what's interesting is that while in the 1980s and the 1990s, it was Black women who were at the top of the number and rate of people who were being tested and surveilled and criminalized and mass incarcerated. What we're also seeing now is that it's poor white women who are leading the numbers of who is being tested and criminalized, across, particularly in these states. And many of these arrests are being instigated in the healthcare setting. So about 1/3 of these arrests are instigated by healthcare providers. And these are the people that if you're pregnant, you're seeking prenatal care, you're seeking substance use treatment, and what's happening is that you're being reported to law enforcement, or you're being reported to the family policing system. So the risk is that you will be incarcerated or that you will lose your children. And this is just damaging to your ability to get the health care that you need, because you will avoid those healthcare settings if you think that you will be reported to the police or that you're going to lose your children. And this is a practice that is opposed by 15 leading medical and public health associations, including the maternal mortality review commissions of Alabama and South Carolina, who have expressed a lot of concern with how this is contributing to the high rates of maternal mortality. So I will leave it there.
Kassandra, thank you. Yeah. All right, Nathan, over to you.
Happy topics so far.
Yeah, thanks, Nathan.
Unfortunately, I can't promise it'll be much happier. Hopefully our sunny dispositions will be enough to keep us going. I want to introduce you to the concept of HIV criminalization. I want to start, though, by reminding everyone in this room that each and every one of us has an HIV status. That HIV status might be positive, it might be negative, we might know our status, or we might not know our status. So what is HIV criminalization? It's laws that make otherwise legal conduct now illegal based solely on a person's HIV status. It's universally their HIV positive status, or else that create a penalty enhancement, again, because of somebody's HIV status. Many of these laws don't require actual transmission, the intent to transmit, or even conduct likely to transmit HIV. In fact, it can criminalize things that could never be a transmission route. For example, in Tennessee, and I'll come back to Tennessee again in a minute, in Tennessee, a sex worker who knows of their HIV positive status can be arrested, prosecuted, convicted, put in prison for years, and until a couple of weeks ago, required to register as a violent sex offender on the state sex offender registry for life for a conversation about transactional sex. A conversation about transactional sex or sex work is not an HIV transmission route. Neither is spitting or biting, for example. We see that criminalized over and over. Many of these laws also ignore mitigation strategies, such as barrier use condoms. Also, we have excellent medications now. So we have medications that can completely eliminate the transmission of HIV through sex, whether you're the person living with HIV or you're their intimate partner who doesn't have HIV. I'll repeat that. We have medications that either partner can take that can completely eliminate HIV transmission. Overwhelmingly, these laws completely ignore these tremendous advances in the science and medicine of HIV. HIV criminalization is not a red state or a blue state issue. I think you've heard this from my fellow panel members as well. There can be some geographic concentration, but you heard 46 states, I think was the number, right? In which people who are pregnant have been criminalized because of their pregnancy. We see that with HIV criminalization as well. This is from our friends at the Center for HIV Law and Policy, and they have excellent in-depth analyses of each of the laws in all of these states. The font is small, but you get the idea. From coast to coast, people living with HIV can be criminalized because of their HIV status. So we talk to policymakers often, tell them, first of all, you have these laws on the books. They're often surprised to learn that they're still there. They think the HIV epidemic is something that went away in the late 1990s, perhaps. That's not the case. These laws usually were passed in the 1980s and 90s, motivated by tremendous fear and stigma, HIV-related, but also often racially coded. There was substantial homophobia as well. In fact, HIV was originally associated way back in the very early days with the 4 H's. That was Haitians, Black people, heroin users, homos, and hemophiliacs. And we see that legacy of otherization, of stigmatization, carrying through today, also in enforcement. So this is Ohio. We just released a report on HIV criminalization in Ohio. There are 6 laws in Ohio, by the way, that criminalize people living with HIV. And you can see over the last 2 decades, enforcement has continued apace. We don't see a tremendous downward trend over time. Ohio is not unique. I want to go back to Tennessee for a minute. The statute that I referred to is called aggravated prostitution. That's their language. What we found when we looked in Shelby County, that's where Memphis is, the overwhelming majority of people arrested, convicted, and put on the sex offender registry for life were Black, 75% Black women. That's both cis and transgender Black women in Shelby County. Over 90% of those arrests were in the context of a vice squad sting operation. So the allegation is an undercover police officer was solicited by a sex worker. And again, that's not an HIV transmission route. Tennessee is not alone. Again, from coast to coast, we see the same racial disparities that you see in the enforcement of pregnancy criminalization and the criminalization of substance use. And whether you're comparing it to the state population or the population of people living with HIV, overwhelmingly Black people are disproportionately affected, but not just Black people. Women are overrepresented, sex workers are overrepresented, and especially people at the intersection of these identities. I don't make policy recommendations in my day job, just the facts, but I'll leave you with these words from the CDC. They say, after 40 years of research, these laws are outdated, do not reflect the current science and medicine of HIV. They have been shown to increase stigma, decrease testing and treatment. And in fact, the CDC and the White House have both called for repeal or modernization of HIV criminal laws. So I'll leave it there.
Thanks so much, Nathan.
I just did this yesterday, too. To lawyers, you're much more exciting than the lawyers.
Okay, I'm a lawyer. Don't say bad lawyer. Speak for yourself. All right, so these subjects are indeed deeply distressing and depressing. I am a tried and true optimist. So I think I'd like to begin with an optimistic question. One of the observations that I have with this issue is that it's siloed. That if we look at the four of us, I'll represent the criminalization of mental illness, Kassandra, substance use, pregnancy, HIV. Why are we all not working together more? And is there hope for that? You know, Kassandra, maybe I could start with you, because I know that Drug Policy Alliance has been trying to kick off an intersectional movement.
Yeah. I am very hopeful, actually, right now, because one of the things that we actually just talked about in the back was like, the people that we're fighting are all using the same playbook, right? There's not much innovation on their side. It's like stigmatize, racialize, incarcerate, right? And then scare everybody about them. And so for us, we're like, if they're using the same playbook, if we get together, we can like build strategies across. And so one of the things that Lourdes and I are part of is really figuring out how do we move past decriminalizing behaviors or identities and actually talk about how do we decriminalize communities? Because the people that are being criminalized for HIV or pregnancy or drugs or mental illness are the same groups of people. And they're using the same strategies. And so it's not actually rocket science for us to actually figure out strategies that can disrupt their power bases if we're talking together. And so one of the things that we've been doing is building tables of folks to have conversations about, okay, so what is your decrim strategy and what is their decrim strategy? What state are you going to? Okay, we'll go right after you, right? And really try to figure out how are we doing the sequencing so that we can actually build the comprehensive nature of how do we fix this? Because the problem is, if we decriminalize drugs, then they criminalize homelessness, right? Or if they decriminalize healthcare, then now we're in the Supreme Court criminalizing homelessness, right? And so part of the thing is like, this is kind of whack-a-mole. They're playing whack-a-mole. So that means that we actually have to stop playing whack-a-mole and just flip the table over and figure out how are we gonna create a new table. And that will only happen in the work that we're doing currently now about having conversations about what do we need to be doing to show up in each other's places to get people to focus together.
Nice. So yeah, Lourdes, Nathan, barriers to that? I mean, I want to stay optimistic, but you know, my feet are on the ground.
I mean, and I say this as a former Ford Foundation program officer, it's, you know, the movements are siloed partly because the funding is siloed. So we need to address that, and we need to work much more intersectionally. I have this fantasy of a national I Am a Person campaign that really challenges the dehumanization of various communities for different reasons, including people with disabilities, and people who use drugs, and people who access abortion and people with HIV status, right? It's like we need to understand, as Kassandra was saying, this is the same playbook, and we need to resist the use of, there's always like some terrible stigmatizing story about somebody who acted really badly or supposedly did. We need to resist those stories. First, the first thought should be there has to be more to it, and resist then creating policies that impact whole swaths of people based on that terrible story, which we see in our spaces all the time, right? And which operate, this is what happened with the myth of the crack baby, right? Which never materialized. That's been a myth that's been debunked, but Black women were slandered, basically. So those are ways that we need to work together. We need to work very intersectionally. The funding has to be intersectional too. We have to be one movement.
I'll just add that we all, I think, in talking to communities that ought to be our natural allies, face the stigma that the communities we're normally studying and advocating for on a daily basis also face. So my organization, the Williams Institute, does lots of LGBT-related law and policy. Many people don't want to talk about HIV. Of course, they had to, I think, in the 80s and 90s, even into the early 2000s, but they don't want to talk about it anymore. And in fact, when I'm at a party or a reception with people working on LGBT-related issues, and I say HIV, you can almost see people flinch occasionally. So I think rather than focusing on the silos between us, which I think are there and we need to break down, I'm going to focus on the work that I need to do in my own communities to make sure that I'm also embedded in broader movements that ought to be a home for example, HIV decriminalization.
Yeah, and I want to pick up on this. I mean, I think culturally, when we look out at storytelling, pop culture, deep-rooted narratives, like Lourdes, thank you for bringing up the example of the crack baby. How do we start to disrupt those narratives? I mean, Nathan, I think you're talking, we all have a responsibility as people standing, firm in this movement to use our own voices. But what else do you all see, again, staying on the optimism track, that's promising, narrative shifting, that might be afoot, if anything?
I'll just start with, I think now at least, a fundamental principle in the HIV decriminalization movement, which is the meaningful involvement of people living with HIV and AIDS. That doesn't mean just having one person as a token at the table. That means incorporating people into leadership positions, because we've found over and over the data that I do for a living is helpful. It's those personal narratives of the people and communities most affected by criminalization that, at least in my experience, have had the furthest reach. And I'll give you a concrete example. When you're unable to sleep tonight because you're too excited from the conference, Google Diana, True Not Crime. This is Diana Oliva. She, I apologize, happens to be at Gilead now, was criminalized because of her HIV status, is also a fierce advocate for herself, the communities she represents. Please watch her video this evening. And I think you'll be moved, as I have been, by her.
I mean, I think in the abortion space, for example, there's been huge progress, right? It's now, first of all, it's no longer the political third rail, as we see. Right. And that was really the work of the abortion storytellers, groups like We Testify, people, putting abortion stories positively in pop culture narratives. When I was at the Ford Foundation, I worked with my colleague, Rocio Cordova, and we supported a Hulu television series called Islos High. It was an all Latino cast, and it included both a positive abortion story, but also a story of a young woman who gave birth and wanted to keep her child, because that's also stigmatized, right? Young parenthood is also stigmatized. So we really wanted to, and bring a reproductive justice lens, which is not just about not having children, it's about having children and being able to be supported to raise your children in sustainable and safe communities, right? So, which is, women of color, Black women in particular, really have brought this to the repro movement. And so, and now, and if you're interested, the Advancing New Standards in Reproductive Health at UCSF, they actually have an online abortion on-screen database so that you can see all the places where abortion stories have been written into. And one of the short films in this year's Oscars was an abortion story. It's called Red, White, and Blue. It's a woman of color writer and producer, Nazreen Chaudhry. And it's, if you Google it, it's a 23-minute film, and I would recommend that you see it. I mean, and I think we have to replicate these efforts around people who use drugs, people who have, who are struggling with mental illness. We need to humanize people, right? Because it is too easy to villainize and stigmatize people if they're not human, right? So,
and if they're not in the room.
And if they're not in the room, absolutely.
And we seem, Kassandra, I know you can respond to the narrative question too, but I can't help but feel sort of at the back of my brain, we're living in this time where I feel like certain narratives from the 1980s and early 90s are coming back as sort of public safety and fear. I mean, certainly in New York City, we National Guard on the subways and all of this sort of, palpitations of something's afoot. How do these cross-sectional movements respond to that?
This is an excellent question. I grew up in Giuliani, New York, right? So I grew up in the 90s when Times Square was not great, and then all of a sudden it turned into Disney, right? And
I remember that well. Yeah.
And it was one point where my mom was like, "You can't go there," and then she was like, "Yeah, go there." Okay. One of the things the biggest thing for us is recognizing is that we cannot go alone because of the narratives. And the silification makes it impossible for us to do that because the narratives are comprehensive. Because the narratives don't just hit on one fear. They hit on all the fears, always reinforcing all at once. So for example, an organization like DPA, where we have worked to decriminalize drugs, in Oregon, we worked to do that. We decriminalized drugs in 2020 at the same time that homelessness skyrockets in Oregon. At the same time, fentanyl hits the West Coast in Oregon for the first time. So now you have a more toxic drug supply that is increasing overdose deaths, but you also have an increasing visibility of unhoused people. And some of those unhoused people are using drugs in the street. And we are caught in the middle because we're focusing on don't incarcerate people for drugs. This is not useful, as you saw on the slides. But people are like, we don't want to see people in the street. And we're scared because the narrative is those mentally ill, drug-using, unhoused people, they're dangerous. They will make everything dangerous for you. They will be wielding like guns in the street and all that stuff. And we can't see them because if we see them, then it means it's more dangerous. And so for us, in an organization that only works on drugs, if we can't speak to mental health, if we can't speak to unsheltered folks, if we can't speak to all these other issues that are showing up in the street, but we are the people that pushed forward a progressive piece of legislation, and that is now what people are blaming for all these other issues, we're at a crossroads. Do we throw the other movements under the bus and say, it's not us, it's them? Yeah, you really do need to criminalize those people, right? But the problem is those people are my people, right? So even if the thing that they're not presenting with is drugs in that moment, they're still my people. And I think part of the conversation around that narrative and the policy making is recognizing that these are all our people. And how are we moving as a block together to figure out what are the resources and interventions that might not be our policy agenda, but might be necessary for my policy agenda to be optimized, right? So I need everyone housed. I need everyone to have access to affordable mental health care. I need everyone to have, just as much as I need them to have access to substance use disorder, even if that's not my remit, It is the necessity for my remit to actually be actualized.
Right. It's like Jonathan said, none of us is well until all of us are well. And I think that that's very, that really resonated with me when he said that. I'm going to imagine, Lourdes, Nathan, that you feel as Kassandra does. So I want to go into something else because I want to leave ample time for questions since I know people are like, I had a question. When we were prepping Lourdes, you talked a little bit about junk science. And today, Nathan, you've brought up, the sort of reality of HIV treatment and care and the laws and how those do not align. So where are we in this world of junk science and not legislation that's not catching up with the reality of treatment and care and science as we know it?
Yeah, absolutely. And as we saw from our first keynote speaker, there's a lot to critique around supposed science, right? But there are a lot of unsubstantiated claims that are being made in order to incarcerate pregnant people who are poor and pregnant people who are people of color. And let me just say, I need to address why I use the word people, because I know, there are people who are all over the map on this. I use people because pregnant women are people too, right? In terms of, who's the living, breathing person in this equation, it's the pregnant woman. And at the same time, there are trans and non-binary people that have the capacity of pregnancy and who become pregnant, and it's dangerous to them and their health and well-being to ignore them.
That's right.
So we need to be inclusive as well. So I say people. So the unsubstantiated claims around, for example, that like meth and marijuana cause pregnancy loss. Well, that's not true. It's not mifepristone, right? These things do not cause pregnancy loss. Sometimes there's coexistence between having a miscarriage or stillbirth by someone who used a substance or allegedly used a substance. It's not cause and effect, right? The other one is the overblown claims on exposure in utero to a substance. So because people are being criminalized for risk of harm, just for the fact of testing, having a positive tox screen, which is not a parenting test, right? Another really neat one is this unreliable forensic test from the 1800s called the lung float test, which if it conjures up, floating women to test if they're witches, So what happens in the situation of a stillbirth is in the autopsy, a piece of the the stillborn's lung is floated in water, and if it floats, that baby must have taken a breath, and that means the parent killed them, the mother killed them, which is not true. It's an unreliable test, but it's still being used by prosecutors and accepted by judges to incarcerate people. So for felony murder, these for experiencing a stillbirth. So these are just some examples, but there's a lot of garbage, in this space that we actually challenge in court.
Yeah. Nathan, do you want to add anything to?
I think with HIV criminalization, actually, the science can win policymakers over. I think it's critical, actually, if you're a mental health, public health practitioner, if you're in private practice as a physician, if you have some of that domain-specific knowledge and can be a trusted expert. We often encounter policymakers who simply don't know basic biology, science, or medicine, and feel the need to posture on things that actually behind closed doors, if they were just able to ask questions, I think could get them a lot of the way there. But the advocates then need those trusted experts to be trusted by the advocates as well, but then to be able to go into that policy space as a supporter, as a supporting actor, not as the star of the show, to provide that trusted guidance to policymakers. I really do think that in a lot of cases, and I don't have to go to state houses often, so I'm a little bit naive about this, but at least with HIV, I think you can get people a long way there.
Mm-hmm. Do you share that optimism, Kassandra?
As someone who does go to the state offices quite a bit,
reality check. Yeah.
I think that the science and the facts can supplement.
Mm-hmm.
But I think sometimes we do have to recognize that it doesn't matter any kinds of facts. Some people just don't want our people to exist.
Mm-hmm.
And I think part of the strategy that we're consistently developing is that you can't rationalize with someone who doesn't believe you can exist. What you have to do is lessen their power.
Mm-hmm.
And so I think sometimes, my dad says often, Cass, when you eat oatmeal, you don't stick your spoon in the middle. You work your way around the edges, right? And so for me, I think part of about the information stuff is like, how are we going around? And so that by the time we give them the facts, they actually have no choice. They actually don't have that much power or that decision making and what we actually need them to do. But I think all those things are important. But I think especially when it comes to highly marginalized and stigmatized populations, like people who are struggling with mental health, people who are struggling with drug use, that the level of dehumanization is one that facts alone will not restore.
Mm-hmm. Mm. That's really profound. I want to turn to questions. If we have any, we can begin here on the left.
Hi, can everyone hear me?
Yes.
Mm-hmm.
Hi, so my name is Christina Sparck. I am the mental health chair of the New York State, Assembly District, thank you, Assembly Member Monique Chandler Waterman. And I'm also a peer with lived experience. I have a serious mental illness, bipolar. I live with PTSD and general anxiety. And thank you for having this panel today, and thank you for having this forum today. The purpose of the task force is basically to break generational trauma through civic engagement for BIPOC communities. I understand, I'm going to school now, so I'm learning this stuff, okay? Mm-hmm. So I understand that political determinants of health contribute to a lot of health disparities in our marginalized communities, which you just discussed, HIV, unhoused, and birthing people and moms. We can all agree that creative solutions and strategies can make changes to change the narrative of decriminalization and destigmatizing these communities. Active collaboration and shared decision-making, which you all discuss, is a recipe for success as it will redress the deep inequities faced by peers. In New York State, recently, and just last month, we had campaign for the Seat at the Table campaign for all peers from all our communities to sit at the table with legislators, to hear our stories, to gain power, and promote in order to shape the policies to promote healthy outcomes. And as again, I think Nathan, you said, none of us are well until all of us are well, correct?
Oh, that was the previous speaker.
I'm sorry. So my whole thing is that if we're doing this in New York State, if we're getting peers together to sit at the table, do you feel that we can get the country together to hear our voices and shape policies for the entire country?
Ooh, who would like to answer that? I think it depends on the day. Yes.
I think we have to start within the across social justice movements, because we haven't been in the same rooms together. So we have to start there and work out from there. That's what I think.
Right. And I appreciate you, Lourdes, reflecting on your time at Ford and recognizing kind of the role. We have funders in the room. Of course, it's a philanthropic organization. And I think that philanthropy could make some changes that could help on a national scale if we can support breaking down silos and really working together more collaboratively.
Briefly, I'll just add,
Nathan.
We can also play a role ourselves when we're talking to our own funders, say, I'd really love to have somebody from reproductive justice with me or somebody working on a substance use disorder with me.
Mm-hmm. The only thing I would say is I definitely think that's possible because in the drug policy space, we have an active, not only participation, but part of the thing that I really focus on is I don't want a seat at the table. I want to call the meeting. And so like that part of the conversation is like a lot of our drug user, I think our organizations have to support the organizing of impacted people. Yeah. So in our drug policy space, we support the organizing of drug users to create the agenda and actually to interrogate the work that we're doing. So that they're not coming to my meetings, but I'm going to theirs. Because until philanthropy funds people that use drugs at the rate that they fund people that go to degrees to do the work that the people that use drugs want us to do or need to do, I need to redistribute our foundations and our leverage, our support, so that drug user unions are stronger. And so an example of that is like Vocal New York, which is a nonprofit organization that organizes people with HIV/AIDS who are unsheltered, who are drug using, who have multiple member unions. They started in a Vocal New York, we funded that. They started a Vocal Kentucky, we funded that. They started a Vocal Texas, they funded that. They're gonna launch a Vocal US, and we will fund that, right? Because it's really about making sure the people that are impacted are driving the conversation.
Mm-hmm. Kassandra.
Hi.
Joni?
Hi, I'm Joni Schwager from the Staunton Farm Foundation. We're a philanthropic organization in 10 counties in southwestern Pennsylvania. We only do behavioral health, mental health, and substance use. The one thing that I always find missing from these conversations, and thank you so much for this panel, especially adding abortion, I think was really brilliant. The one thing I always miss is that what we can do, okay, there's great, we can create policies. We have to get legislators in office in order to make a change. If you don't like what they say, change their faces. And we have to put people in legislative power that are going to accept and believe and pass laws based on all these policies. And so I would also encourage, I wonder if any organizations here have voter registrations in their waiting room. Most people don't, and that's certainly something you can do.
I would offer that we have a C4, right? A political organization. And I think the getting people in office, yes, but they can't stay there saying the things that we say. We have to keep the voters on their side and advocacy organizations, because we elect people all the time and they get booted, right? Because the people don't stay with it because they see the things on the street. So I think, yes, we have to get legislators in there, and advocacy organizations have to shift or provide them the support so they can stay in the seats, because a lot of our peoples get in and they get pushed right out.
Especially women and people of color.
Correct.
Thank you.
Thank you, John. Tahir?
Hi, Tahir Duckett, Georgetown Law, Center for Innovations and Community Safety. Thank you so much for this panel. Really, really an incredible intersectional conversation. I mean, I don't feel good. I apologize, but you know, maybe this was related a little bit to the last comment, because it strikes me that some of what's happening here is there's this bloodthirst. There's this energy for punishment, and it's all about people that we don't like and stuff that we don't like, right? This thing we don't like. And in as much as part of the conversation is about changing and saying, hey, maybe we shouldn't be so focused on not liking X, Y, and Z thing, part of it is also, as long as that bloodthirst exists and that underlying carceral logic exists, that we're going to be fighting these same sorts of battles to try to otherize and criminalize somebody. And so I'm wondering to what extent y'all have thoughts on how to change this sort of overall cultural sort of energy towards punishment, otherizing, criminalizing.
I think you're absolutely right. This is nothing new. I mean, I was reflecting when you were talking about growing up in New York in the 90s. I grew up in New York in the 70s and 80s in Bed-Stuy, right? Bed-Stuy, do or die, right? And so, and it's the same thing. It was divestment of resources, and the response being policing and the carceral system, which is much more expensive and has worse outcomes, right? But what's underlying it is maintaining a particular social order, And we need to not forget this. Part of the book banning and the whitewashing of African American, the AP history, it's about not learning these recurring patterns. I was at the Cincinnati Underground Railroad Museum this past weekend, and it reminded me that these state rights, the argument around state rights, that originated with the forming of the Constitution, where the slave states wanted to be in charge of regulating slavery and not ceding it to the federal government. And these are the same claims, the same arguments that being proffered, on abortion, on, criminal laws, on all of these things, right? It's not that the federal government is a panacea. I'm not saying that either, right? But, we forget history. And we need to, like the young Lourdes, which was, the Puerto Rican version of the Black Panthers in Chicago and New York, right? They had a health platform that included abortion rights and that included advocating against sterilization abuse, that result in their overall platform is what is the Patient Bill of Rights today.
That's right.
But we don't know that history, right? So we need the spaces of continuing to learn this history so that we can go beyond it, so that we don't have to keep, fighting the same battles over and over again. And so I don't know, we need like new versions of freedom schools or something. I don't know what it is, but we need to, we need to understand that this is not anything new. These are recurring cycles, recurring themes, and we need to figure out, the moral arc of justice. Can we stop spiraling and just get there? So I don't know. Like we need more. We need to keep teaching the new generations the same history so that we can innovate forward and not just keep fighting the same battles.
Oh no, you can follow that one.
Oh, okay. I was just gonna say that part of the innovation, I think there are some people that are committed to punishment, but I think there are a lot more people that are resigned to punishment. And so there's a level of innovation that we need to do on our side, so that we can replace the punishment that they're holding on to. Punishment offers immediacy. And when we're talking about these complicated human behaviors, the things that we often can't offer is immediacy. Because that infrastructure of criminalization is invested in, it's developed in so many ways, right? It's building upon other systems of criminalization. So they're never starting from square one, right? And so there's a need in order for us to be able to disrupt the commitment to punishment, the bloodthirst, the carceral logic. It's like they think it's logical because it's faster. And that's and part of the thing that I think, my colleague Elise is here, who's been pushing DPA to really like study more around disability justice, is like the commitment to immediacy is the other thing that we really need to contend with, because it doesn't give people patience. That's why it's easy for us to pass a law and for it to be reversed, because it doesn't meet the thirst for immediacy. That's why it's easy for an elected official we fight to put in gets pushed out immediately because it doesn't fit our immediacy for what we want to see. Their side is faster, it moves faster, it innovates more. And it goes back to the funding. We don't get funded to innovate. And our innovation, it doesn't go as fast as the innovation of criminalization.
Can I just add briefly, these are two very big and I think beautiful and comprehensive visions of the problem and potential solutions. I'm going to offer a very small, concrete suggestion. You started, the questioner started with otherization, which leads to stigmatization and then criminalization. All of us in this room potentially could become a person living with HIV. Many of us could become pregnant at some point. Many of us might use drugs and other substances now, might have a substance use disorder. Sort of interrogate your own internalized stigma about HIV, about abortion, about drug use. This evening, again, when you're falling asleep, maybe it's not the happiest thing, but why is it that I can't say that? Why is it that I can't ask my friend, when was the last time you had an HIV test? What is that fear inside of me? What is that potential fear I'm imagining from them? And I think if we start to unpack that fear, we start unpacking that otherization and break the chain.
We have time for one more question.
I will let somebody else go.
Come on. All right. That's very kind. Other person? Oh.
Go for it.
Hi. Hi, Kassandra. Hi, Nathan. Sterling Johnson. I'm in the National Survivors Union, Drug Users Union. Thank you, Kassandra, for calling that out. And this isn't meant to be difficult, but it's just meant to just suggest there's a certain amount of co-optation over this idea of lived experience that is occurring. And the people that are leading the criminalization are people, well, in Philadelphia, there's a person that says, I'm in recovery, I've gone through trauma, I know exactly what these people have gone through. The same thing is in San Francisco. There's a supervisor that says, I am in this community, and this is what is demanded for my community to be criminalized and forced into treatment. So, but we're seeing that co-optation in many different ways. So I'm just wondering if you could kind of speak to those dynamics that are happening. Thank you.
And oh, Zoe.
Yeah, I'm happy to start. Happy is maybe not the right word. This has been a problem, not just in HIV decriminalization, but HIV advocacy for decades. My HIV status is negative. I'm happy to share my status. I'm in a status neutral way, and I want to live in a world where everybody feels the same way. The person who leads this research at my organization, who started it, is a person living with HIV. I think it's important for him to say that every time, as he did yesterday, speaking publicly in a forum like that. The panel we put together, we always demand at least 2 people out of 5 in the panel that I was on. It's not enough. It's not enough in part because we don't have the connections. I don't know what it is. We don't prioritize building the relationships that we need to do in order to make sure that people with lived experience are here on the stage today. In fact, in our planning call, I asked this. I said, I hope that we have the opportunity to have someone with lived experience here on the stage. I think it's fundamental, and I'm glad that it was called out. And I'm here to own that and ask that myself and all of us do better about this.
Mm-hmm. But I think what the question was, that there's some people who are like wearing the mantra of lived experience, therefore I'm going to say incarceration is okay and it's being legitimized, right? I think that's your question, right? And right. So I think, yes, that is a problem, and we should always, just be, yes, and just because someone says they have a lived experience, like your brain cells should not drop to your shoes, right? It's there has to be also interrogation, and it has to be married with like, what are the facts, what's research, and then what's also good for the whole community. Like, I can't speak for the whole Latina universe, right? Just because I'm one person with that experience. I can't even speak for everybody who grew up in Bed-Stuy during my time, right? Because other people had different experiences, right? Other people had different parents, right? It's just a different experience. I had one particular set of experiences that I can speak to. It's informed, but it's narrow. So we have to marry all of these things and be able to chew gum and walk at the same time.
I'm very good at that. You'll see that on my LinkedIn profile. I want to, be observant and respectful of the time, and I want to thank all of you and make an observation or two, if I might. This panel began with some pretty dire facts and data, And I think what we've witnessed here is what we really aspire to as the Sozosei Foundation, which is being propelled by facts and data, remembering history, feeling who we are in our hearts, remaining curious, respectful, open, and willing to question our assumptions. And so I really thank each of you from the bottom of my heart for your excellent participation today, for your contributions to the world. And I think together we will decriminalize all healthcare.